I'll speak about, so I think it's an interesting session in the sense we are learning about various infiltrates in the allograft biopsy and their relevance. So I'll take two of these and we'll just quickly come to that. So I think it's at the outset, it is important to all of us know that these infiltrates are not mutually exclusive in the biopsy. Almost all of them occur together. It's only their relative proportion, which one predominates one over the other or something or the other, depending on the clinical scenario, which dictates the clinical presentation of that patient. And it is important to know what is the dominant type of inflammatory infiltrate, and that will help us a lot in understanding what the clinical picture is behind it. Now, all of us know, right, that inflammation is a very important indicator of graft distress. So, inflammation is one thing which we, even at a low power, when we look at the biopsy, the first thing we look at is how inflamed the biopsy is, right? Even before going into see what are the type of cells and other things. So, that's the first step in looking at the graft biopsy, the first step. And importantly, since inflammation spans a variety of clinical etiologies ranging from rejection to infection, and infections also bacterial infections, viral infections, it is important to determine what is the type of inflammation in the allograft and try to decipher what is the etiology behind the inflammation so that you can give out a proper diagnosis. And that's where all this talk about type of inflammation, the type of cells in a graft comes in. So this is just a general algorithm which most of the renal pathologists follow when they look at inflammation in the graft. The idea is to tell whether there is a rejection, is there an inflammation or an infection. If there is infection, is it bacterial or is it viral? Or if the inflammation is too much, is it actually transforming or looking at a lymphoproliferative disorder? So even a lymphoma can be a manifestation of inflammatory process. So these are the various etiologies an inflammation can span. And as renal pathologists, we know this is what we look at. So inflamed graft is always a cause of concern. And as we go down, we realize we try to see what are the kind of cells. So these could be lymphocytes, these could be eosinophils, or these could be plasma cells. So most of these cells, as I said, occur together. And it's up to us to look at the biopsy diligently and figure out which one is the dominant one and what is the clinical scenario in which this inflammation is occurring, and then make an appropriate diagnosis, whether it's a rejection or is it something which is happening as a part of reactionary process or so on and so forth. Now we'll start with eosinophil. Eosinophil is a very interesting cell in the sense it has multifunctional, right? All of us know. So there are starts from multipotent cells, so it has dendritic cell functions, macrophage, it can handle bacteria, it has an endothelial function, even it has an immunomodulatory function. So it's a very versatile cell, and that is why its presence in a renal allograft biopsy is of utmost importance. The immunomodulatory function or the immune modulating or immune altering systems mechanisms of eosinophils are of great importance, and this is the reason eosinophils are not good in a graft. So whenever we look at eosinophils, if it is occurring in the setting of rejection, we know that this is not going to respond well to the conventional treatments. And if there are eosinophils because of some other infection, we need to figure out what that infection is. So it's an important thing to see. So the eosinophil which we see on the tissue looks slightly different from which looks in the blood. And a very diligent examination sometimes is required to see eosinophils. Sometimes the granules may not be very prominently seen in tissue sections, and you have to be very careful while seeing them. Now, if we just take an overview of eosinophil infiltrates in the renal allograft, so this would be the broad heading. So it can occur as a part of T-cell mediated rejection. You can have a few eosinophils here and there. It can even occur as a part of ABMR. So I will come to a few papers which have validated this concept. And there is a separate subtype of cellular rejection, which is an eosinophil-rich acute cellular rejection. So even that is a separate definition by itself. Not only that, just like in the native kidney where you have interstitial nephritis, allograft patients with allografts are also exposed to a lot of drugs, right? And the same drugs can cause interstitial nephritis like pictured in the graph. So if you look at it from a broader angle, even a rejection is an interstitial nephritis. Only thing, it is occurring in an alloimmune setting. So an allergic interstitial nephritis sometimes may become very difficult to distinguish from a classical interstitial nephritis, and probably I have a case to show you on that and how you can distinguish an interstitial nephritis from a rejection in an allograft, and all of us know what the implications are in terms of treatment. And then infections, of course, the fungal infections are known cause of eliciting a lot of inflammatory response. Whenever you see a lot of eosinophils, you have to go down and do all possible stains to just exclude that fungus. Sometimes the fungus may be hiding behind that infiltrate, and you may mistakenly make a diagnosis of eosinophil rejection, whereas the diagnosis is a fungal infection, and the results can be catastrophic. And finally, there may be conditions where if you are not careful enough to look at the extravasated time phosphoprotein, you can again make a mistaken diagnosis of rejection of to a physiological process. So even this needs to be taken care of. So this is just a broad overview. I'll just go through a few articles which have addressed presence of eosinophils. And if you look carefully, this paper is from 1986. So even before the BAMF classification came in, the early transplant period, they realized that the eosinophils are actually associated with acute allograft rejection. And even till date, there is no separate category in BAMF to call eosinophil rich rejection. Probably we are not diagnosing it, or maybe it's not very common, but I'm sure in time to come, there will be a important addition to the whole BAMF classification. Now, as the knowledge progressed over a period of time, the presence of eosinophils in allograft rejections remained persistently important. So people kept on recognizing them and realizing that whenever there are eosinophils, the outcomes are not good. So all those things kept on moving in terms of papers, and this paper probably is from 2005, and this was on nephrectomy. So importantly, one won't do a nephrectomy out of blue, right? So nephrectomies are where the grafts have failed. And since this is a very specific kind of a clinical population, finding of eosinophils in a large number of this nephrectomy was an important indicator. So again, highlighting the fact that eosinophils are not good for renal allografts. And there are a few papers from India. So interestingly, when I was searching the literature, we found a good number of papers from India which have come out in terms of eosinophil infiltrates in the graft. And this particular one is from JIPMER, in which this is the case report, in which a POD4 allograft recipient actually had an antibody-mediated rejection in the allograft. Interestingly, this patient had eosinophilic glomerulitis, eosinophilic peritubular capillaritis, and even C4D positivity. So there were all the signs of an antibody-mediated rejection with an eosinophil predominance. So it was not just by chance or just by influx or efflux that eosinophils were there. They were actually contributing to the antibody-mediated rejection, giving a new dimension. So initially, we were talking about cellular rejection, right? Eosinophil-rich cellular rejection, but not only cellular rejection, eosinophils probably also have an important part to play in the antibody-mediated rejection. And this is to be remembered when we look at the graft biopsy. Now, this is again an interesting case report, again from India. This is from Madras Medical College. And this is an allograft recipient 11 months post-transplant who also had a peripheral eosinophilia. So even in the initial papers, which we talked about just now, these two things may or may not go hand in hand. But even a peripheral eosinophilia translating into tissue eosinophilia is a bad indicator, and vice versa. So there are cases where you do not have peripheral eosinophilia, but you can have tissue eosinophilia. So that has a portents a poorer prognosis in the graft. So in this, they also realized, so in spite of all these standard treatments, this patient did not respond to treatment. So the whole idea of having eosinophils is that it does not portend a good response to the conventional therapy. And we have to figure out whether it is occurring in the setting of a cellular kind of a picture or a humoral kind of a picture, so that we can at least try give an appropriate immunotherapy instead of a standard one. Again, so this is also an interesting paper. This is from the group in IKDRC, where this was a large study. So this was a large 5-year retrospective study where they took a cutoff of 4%. So if you looked at the 1986 paper, the cutoff they took for significant eosinophil was 4%. But in later papers, when they started doing it, they figured out that 4 probably is a slightly lower threshold. And now, as a general consensus, although there have not been very scientific studies to that, 10% is the cutoff we take for determining significant eosinophils, similar to what we do for plasma cells. So anything above 10% is significant, and then you look at what the clinical picture is. So this particular paper took 4%. And in this 19 out of 27 biopsies had a coexisting rejection, and the outcomes were not good. So again, re-emphasizing the fact that the presence of eosinophils, either in a cellular rejection setting or an antibody-mediated settings, give a GRAS a worse prognosis than it would do with either of them alone in the conventional setting. And this is the Kaplan-Meier which they drew. You can clearly see the blue line. So the graft survival was significantly lower in the patients in the group, the subgroup which was associated with significant eosinophilia. Now, I initially talked about the immunoregulatory role of eosinophils, and this is something which we don't often realize and understand. But eosinophils have a very, very important immunoregulatory role. And this is a very interesting paper, 2000, slightly older paper, but it's a quite comprehensive review of immunoregulatory roles of eosinophils. And not all of it's an interesting thing to realize they can also express MHC class 2 antigens on their surface. So it gives a good immunological milieu for eosinophils to participate in alloimmune reactions. So, and that is their importance in actually having them in the renal allograft biopsy. Now, quick case. So this is a 34-year-old male with renal allograft recipient, ABO compatible donor brother, uninfluenced surgery, and creatinine rose from 0.9 on 0.6 baseline to 1.2, 1. So progressive rise in creatinine. And on 14th day, the renal biopsy was drawn. So looks good, maybe just for a few infiltrates here and there, not too many of them. 2 or 3 foci of inflammation, but this one particular foci at the corticomedullary junction was particularly important. And you can see there are a lot of eosinophils here. The ones with reddish granules, you can see they are all eosinophils and they are causing tubulitis. So this is an inflammation, multifocal, but more centered towards the corticomedullary junction with a lot of eosinophils. Again, a high power view, you can see a lot of eosinophils and tubulitis in this area. So there was nothing else, no viral cytopathic effects. Eosinophils were about 4% of the infiltrate. So was this a borderline ACR? Was it an eosinophil-rich ACR? Or was it interstitial nephritis? Now the pulse was given, no significant response, DSA negative. So they figured out that patient was receiving rabeprazole, proton pump inhibitors, and since everything else was ruled out, we figured out that this probably could be the reason of graft dysfunction with eosinophils. And when the rabeprazole was taken off, there was complete resolution of the graft function by day 30. So telling an important thing that this has to be an important thing to consider when you look at eosinophils. And I think the key feature here is when you look at allograft biopsies, a great deal of importance should be given to the corticomedullary junction. And one thing which differentiates a rejection, pure rejection from an interstitial nephritis, especially in allografts, that this particular inflammation in TIN is centered around the corticomedullary junction. So it's an important indicator, and if everything else is ruled out, this etiology should be given due consideration. So there is a lot of literature around PPIs. I need not go through that. PPIs are known cause for interstitial nephritis, but it is important to know that a lot of these allograft patients are on PPIs before transplantation as a prophylactic regimen and continue to do so for a few months down into the transplant period. And this may be a hidden cause of interstitial nephritis. Either it occurs as a part of rejection, or maybe it occurs in the background of a rejection, or it occurs by itself. All the 3 scenarios can be there. Just a quick, I talked about the TAM phosphoprotein, and this is not uncommon. So I have seen cases being misdiagnosed as rejection when the inflammation is because of extravasation of TAM phosphoprotein. It elicits kind of a tubulitis and eosinophilic reaction and can be mistaken for a lot of things in native as well as transplant biopsies. In transplant biopsy, more so in early period because of the tubular paresis and some kind of stenting and other things, which gives a back pressure and maybe inspission of TAM phosphoprotein, which can sometimes get out of the tubules and elicit an inflammatory reaction, which can mimic a rejection or an interstitial nephritis. So just a passing thought. Now, quickly we'll go through the plasma cells, the second part. So we've covered the eosinophils. The second part is plasma cell. Maybe I have 5 minutes to do that. Now, plasma cells again are, all of us know, pluripotent cells. They have multiple functions. Look slightly different in tissue. Sometimes they will be very difficult to distinguish from lymphocytes, but a diligent examination would help you to do that. Now, when we talk about plasma cells, etiologies of infiltrates in allograft in a plasma cell, they could occur as a part of T cell mediated rejection. We saw that most of them do have. So almost all cellular rejection will have at least few plasma cells there. There is a separate entity, better defined entity than eosinophil rich rejection is a plasma cell rich acute cellular rejection. And then of course, as a part of viral infections or even as a part of recurrent urinary tract infections. You should remember that urinary tract infections in their earlier part are neutrophil rich, but as the infection subsides or becomes recurrent, these neutrophils are slowly replaced by plasma cells. And if you look at a biopsy at a point where there are a lot of repeated infections have happened, you will see a preponderance of plasma cell. So they're not making a diagnosis of plasma cell rich rejection. We should take a good history, try to look at intertubular neutrophil cast, and then you look at a computer diagnosis that probably these plasma cells are a part of recurrent infections, not as a part of rejection. And then finally, PTLD, which we should not forget. Although uncommon in kidney, it's always a possibility. So a lot of studies have been done on plasma cells in allografts. And one thing which I'll quickly go through is the plasma cell rich acute cellular rejection. Now, similar to what I talked about eosinophils, even as early as 1993, people realize that plasma cells are not good for the allograft, right? Similarly, they realize that it probably isn't, so it was called an interstitial nephritis. So plasma cell rich interstitial nephritis of allografts. It was not called rejection at that point of time. And this is around the time the BAM classification was taking its form. This is 1993 paper. And they realized that plasma cells are not good. They shouldn't be there in allografts. And whenever they are there, the grafts don't behave well as they do for standard therapy. And it was still some time before this term plasma cell rich acute allograft rejection came into vogue. And this was a great work from Lauren Rakusen and her team. So they did a retrospective study of 10 years. And they figured out that they gave a cutoff. They did not give a cutoff in this paper, but they told those allografts which have a large number of plasma cells don't do well. So this was the bottom line message from that particular study. And graft survival was not good in these patients. And for the first time, probably this is a paper around 2004. So this time they defined that 10% should be the cutoff. So if you have more than 10% plasma cells and all the other features are satisfied, including tubulitis by plasma cells, and you exclude other viral infections, then you can call it a plasma cell rich acute cellular rejection. And in this particular study, which was the first study, they also found that there was a higher incidence of interstitial edema in these biopsies. So it was called as a allograft plasma cell rich rejection with major interstitial edema, although maybe it's not very true because of a selection bias, but we do find a lot of plasma cell rejections without edema also. So the literature kept on moving from there. So this is one of our studies at All India Student. This was one of the first studies which actually described plasma cell rich rejection in the Indian subcontinent. We figured out 8 cases of plasma cell rich rejection, and very similar to what was seen in the earlier studies. When we looked out the outcome of these patients, it was very poor. So it was statistically significant. So all of the grafts which had PCAR showed a very poor outcome compared to the control population. And this was the first study from this part of the country. These are a few images from this paper. You can see, so the important point is you should take care that you have to demonstrate that plasma cells are causing tubulitis. So that's a very important thing to, so you don't, just presence of plasma cells should not dictate your diagnosis. You have to demonstrate that these plasma cells are actually crossing over and causing tubulitis for it to qualify as a rejection. Similar to eosinophils, so it's kind of counterintuitive. We talk about T cell rejection and we talk about plasma cells, which are B cells, right? But having said that, it's only a matter of time that we started realizing that plasma cells are not only a part of cellular infiltration tubulitis, they are also important participants in antibody-mediated rejection. And a lot of literature is now emerging to that extent that plasma cells, whenever present in graft, you have to look at the antibody part of the rejection very, very carefully and exclude it. And this is a recent article in which a great deal of review has been done for plasma cell rich acute rejection. I'll just quickly wind it up. Finally, the PTLD. So nothing great about it. Very uncommon in kidney transplants, fortunately. But whenever it is there, it is very difficult to diagnose. So I am sure we did a small study a few years back. It's not published. We looked at a lot of our rejections and we stained them for EBER. We had a good 3% positivity for EBER-ish in cases which we had diagnosed as rejection earlier. So this is one thing which we need to do. EBER-ish should be standardized in biopsies in centers who are doing high volume transplant work. And it is a very useful and easily standardizable technique. Finally, viral infections, plasma cells, they go hand in hand. SP40, cytomegalovirus, immunohistochemistry. One final case, I talked about infections and plasma cells, right? So this is one of those cases where you have a recurrent infection. It looks like rejection, but when you go down and look at the plasma cells and carefully look at, you can see these large neutrophil tubules, neutrophil casts in tubules. And when you go back to the patient, go back to the clinician, you will find that he has recurrent urinary tract infection. So these are the cases where you need to be very careful about. So finally, both these cells are important. Both these cells are not good for the graft, plasma cells as well as eosinophils. You have to do a very diligent examination, standardize your algorithms as well as renal pathology laboratory to detect these changes. And as always, renal biopsy is an indispensable tool for appropriate management, provided you have the correct clinical background. Thank you.